You're listening to the Smart Policy Podcast, a production of the University of Tennessee's Institute for Public Service. The arc of the opioid crisis is, by now, familiar to most people. Overprescribing of legal opioids in the late 90s caused escalating numbers of people to develop use disorders. In the 2000s, new prescribing guidelines and controlled substance monitoring went into effect, and the legal supply of opioids rapidly reduced, so quickly that many people with opioid dependence turned to heroin to stave off withdrawal. But that only made the problem much worse. And then by the mid-2010s, fentanyl and its multitude of analogues hit the scene, and overdose deaths exponentially skyrocketed. And then the pandemic hit, and the death toll literally doubled. Richard J. Baum is one of those individuals who has had a bird's-eye view of the crisis the entire time. Baum served in the Office of National Drug Control Policy through 6 presidential administrations from the late 90s until he became acting director under President Trump. This month, he joins us to discuss his perspectives.
Especially when I was acting director in 2017, 2018, when the understanding of what was happening with fentanyl was hitting the country and overdoses were escalating dramatically. It was a terrifying time, frankly.
Baum is now adjunct lecturer at Georgetown University, where he is teaching a course based on his comprehensive book, Inside America's Opioid Crisis, which draws on more than 3 decades of work on national drug policy. In this conversation, we talk not only about how the crisis unfolded, but we focus especially on the current moment defined by shifting drug trends, unpredictable overdose spikes, a large gray market of unregulated dangerous drugs sold as supplements, and the rise in stimulant use, even as fentanyl overdoses decline.
We have still incredibly high overdoses. A football stadium a year. Americans are dying, and that should never be acceptable. We need to drive that down further. So we just need to be faster. Things move more quickly.
Baum has learned a lot from his experience on all aspects of this crisis, like treatment.
But the key to successful treatment is the quality of that treatment and the duration of that treatment.
Prevention.
We have just decided as a country not to give every student in the United States evidence-based drug prevention education information.
And how best to inform the public about the dangers of each new drug threat.
Take a lesson from Coca-Cola and let's invest in good messaging for our young people. It's just a dereliction of responsibility that we're not doing media messaging and doing it on the cheap.
As always, any opinions expressed in this episode reflect those of the guest and do not represent the opinions of the University of Tennessee.
Great. Well, fabulous to be with you, Jeremy. Thanks so much for having me at the Institute for Public Service. Appreciate what you all do. It was great to meet you out at the RX Summit a few weeks ago in beautiful Nashville, Tennessee. My name is Richard Baum. I am a long-term staff member at the Office of National Drug Control Policy until late last year, where I retired because I had to leave government in order to publish a book I had been toiling on for 3 years. The book came out early this year. It's called Inside America's Opioid Crisis, 12 Hard Lessons for Today's Drug War. I have a lot of free information on my website, richardjbaum.com, including videos and info about the book. If you're interested in buying the book, that's great. That's available on Amazon. My objective now that I've departed government is really to share my lessons learned in government about American drug policy and to think about the future, about what we need over the next few years as the opioid crisis evolves. So it's great to be with you today.
Thank you so much. It's really an honor to have you here. You were at the Office of National Drug Control Policy for quite a while, through 3 terms, and I would love it if we could get a brief.
Yeah, actually six presidential terms, 28 years.
Oh, goodness.
So I joined in 1997 under Bill Clinton, and I know I should make this point. So I was a White House civil servant, meaning that I have permanent position like other civil servants in government. But, when the president changes, our bosses changes. And when you really think about it, I think it may seem odd that one moment you're working for President Trump, and the next one you're working for President Obama. But it's good that there's some qualified, experienced experts at the key agencies in the White House, OMB, and Office of National Drug Control Policy, National Security Council, were there to support, advise, and serve for whoever the people elect.
So from 1997 to the late 2010s, 2017, 2018, when you become acting director, this is the arc of the whole rise of the opioid crisis. You saw the rise of overprescribing, you saw the rise of heroin, and then immediately the takeover of fentanyl. I would love to talk about what was happening in the office during this time.
A really good question, Jeremy, because I would have to say that I wish we in federal government were faster in seeing the emergence of first the prescription drug epidemic, and then as it evolved, just like you said, to heroin, fentanyl, and then the poly drug crisis we have today with such heavy methamphetamine and cocaine involvement and other drugs as well. But for most of my career, I was focused on, and the office was focused a lot on cocaine.
Yeah.
And that was, an outgrowth of the crack cocaine epidemic, which admittedly was ebbing in the late 80s and 90s, but still a very serious concern. And over time, it was 1996 when OxyContin came out. It was the early 2000s when we began to see the increase in opioid misuse and overdose. And then at the start of the Obama administration, 2010, 2011, there was really a major focus on the prescription drug crisis. And I really wish that we had gotten involved earlier on it. And I also wish that during the Obama administration, we were able to invest more resources, energy, and focus on it. To be honest, drug policy wasn't a top priority of President Obama. He was concerned more about the social justice aspects of drug policy. And don't get me wrong, that's an important part of it. And the number of arrests for marijuana, almost 800, 900,000 a year, was concern. And I know that the Obama administration wanted to deal with that. But at the same time, we had this rising prescription drug crisis that ONDCP was working hard to address.
Yeah, those are really interesting points, because I worked in the hospital in the later half of the Obama years across emergency departments, and we saw what, from our end, because hospitals at the time didn't see fentanyl coming, didn't have testing capacity for it. We knew, quote unquote, heroin was getting bad because we kept seeing the overdoses getting worse. So something was happening with the heroin. We knew that. We knew it was strong, and more people seemed to be doing it. But it kind of caught us by surprise. Nobody really started talking about fentanyl until the latter half of that decade, and at least at a large enough scale to where it became a common name. Now, on the flip side, we're on the other end of the pandemic. We don't necessarily need to cover the entire trajectory of fentanyl, the doubling through the pandemic and everything, but we've been hearing some great news over the past few years. 3 consecutive years of decline, at least in Tennessee. Some states are seeing a worsening, but for the most part, the national average of overdose deaths is coming down, thankfully, for the first time, and in significant enough quantities in this way. That decline is starting to slow down, at least in 25. So the problem is still pretty significant, and we are still, at least 2025 data, above the level when President Trump declared it a national emergency in 2017. So plenty of work still to be done. Fentanyl is still a large problem. Meth is still a large problem. But we're also seeing a resurgence in cocaine now again. So, and not to mention some of these other drugs, cyclorphine, medetomidine, xylazine, these waxing and waning trends that are causing a lot of chaos and confusion at the first responder level, at the overdose prevention level. So with all that in mind, these past few years, what would you say we've been doing right? How have we been getting these numbers down? And then on the other end, what should we be thinking about now that this decline is slowing, appears to be slowing? How do we ramp that back up and keep the numbers coming down faster?
Jeremy, that's a lot of questions, really important ones. And that's certainly Of course, it's a tremendous relief after, especially when I was acting director in 2017, 2018, when the understanding of what was happening with fentanyl was hitting the country and overdoses were escalating dramatically. It was a terrifying time, frankly. And me and others who are working on drug policy were scrambling, trying to understand the facts on the ground, trying to drive change, trying to get investments in the right place. But I just want to highlight one point is that unfortunately, when we were dealing with prescription drug epidemic, we weren't really thinking sufficiently about what could happen next. We were focused on reducing prescribing, and the country did that. However, a significant minority of people who lost access to their prescription opioids migrated to the illicit market. And I think people thought that perhaps the obstacle of injecting would have made it hard for people to do it. Of course, we know you can also smoke fentanyl, but not everybody, not even a majority. But there was such a large number, say around 10 million people who were misusing prescription opioids. The fact that maybe a quarter or so migrated to the illicit market meant a giant number of people migrated to fentanyl use. And especially early in that process, early in that timeline, when people weren't aware of the dangers of fentanyl, when naloxone was getting out, but not everywhere, a lot of people died. And so that was a disaster. And I really wish more could have been done. And I've met a lot of families who have lost a child, often an adult child. And it's really a tragedy that we didn't do more better. But going forward to your question, it's a relief that overdoses are down. And I think that several things that the government, the country did right, the supply side focus internationally in sometimes working with China, sometimes pressuring them, sometimes going to the UN and getting international scheduling of fentanyl, synthetic analogues to fentanyl, other synthetic opioids, all has made a difference. And if I had to rank the cause of the causes of the decline, and I think we're still figuring this out, so I don't want to overstate it, but definitely supply aspect of it was important, and I appreciate everything folks at DEA and DHS and State Department, others did to drive change. But in addition to that, getting out naloxone, trying to get the word out, people not to use alone, increasing availability of buprenorphine, and the direct engagement with drug users, deflection, diversion, all these tools, I think they were a factor. And I think to take a step back now and think about here we are in 2026, we have still incredibly high overdoses. A football stadium a year, Americans are dying, and that should never be acceptable. We need to drive that down further.
Yeah.
There is maybe a bit more time because people now have more tools to manage the consequences. But my concern is the rate of addiction. The rate of complicated, problematic poly drug use is very high. And you're right to mention cocaine. Methamphetamine is very prominent. And some studies, and it was a Millennium Health study out, says that about 85% of people who test positive for fentanyl also test positive for a stimulant.
Yeah.
So people have this complicated drug use, and now's the time with overdoses trending down to focus on getting people into some level of treatment or care. And so that, to me, is the most important question. We know that most people are not proactively seeking treatment. They're not receiving it. And so we've got to drive those numbers up, of persuading more people to get access to treatment. The drug supply has a little bit less concentration in fentanyl. So that's great for now. That won't last forever. It has these other substances in it, and it's still dangerous.
Yeah.
And treatment is more complicated with the addiction to multiple drugs.
That's a perfect point. One of the substances I mentioned, medetomidine, there's been some important conversation around that For example, it precipitates withdrawal symptoms really rapidly and can cause a sudden heart attack. And yet, if you don't know it's there, you may not expect it. So you might discharge somebody, get them set up at a abstinence-based recovery house. They might show up, and then if they don't know to expect it, the need to suddenly get cardiac care from a first responder could take some people off guard. So just as a quick example of those complexities you mentioned, when you talk about the need to get people in treatment, there was an article about Tennessee in Axios not long ago about the rate of opioid use disorder diagnosis in Tennessee was top of the list. And that caused a lot of consternation. But the first thing that popped to my mind was, well, you need a healthcare provider to make a diagnosis. So conversely, it might be a good thing in that people are clearly getting seen and diagnosed, which sets them up to get that treatment in the first place. Perhaps that's part of the puzzle as to why our overdose rates are coming down a little bit higher than the national average. That being said, ensuring that connection to treatment is made is an open question mark across the country. People are trying to figure out how best to facilitate that. Peer support to keep people coming back to appointments has been an important strategy. I mentioned recovery houses. So yeah, open conversation with the support groups, with the recovery houses. These things are all critical. But I would love your thoughts on what is and isn't working with establishing the continuity of care, especially at the policy level.
Yeah, a very important question. I emphasize this a lot in my book because the research is so clear that the key to successful treatment is the quality of that treatment and the duration of that treatment.
Yeah.
And people need a year or more of continuous treatment and then post-treatment recovery support. And systems aren't really built for year-long programs the way they need to be. So I think that is really critical. And the other thing is, I think people get wrapped around the axle over sort of harm reduction versus recovery-oriented treatment. And I think that we really need to stop viewing over it.
Yeah.
Is let us go to people where they are, start them on something to move them in a direction towards recovery at the pace that they're ready to do. And, I think that I think it's a relatively small percentage, but those few people who are supporters of harm reduction who say, oh, well, we can't tell people when to have treatment, or we can't get involved, or it's their right to use drugs if they so choose. I just think that's wrong. And B, even if that I could see that point of view maybe 15 years ago, but now with the drug supply being so dangerous,
Right.
we have to reach out to people and move them in the right direction. And let's just not get wrapped around the axle about the intervention. You don't want to do a syringe service program in your state? Fine, don't do it. People need a lot of things. They need basic health care, they need nutrition, they need a kind word, they may need a place to live, they need help with legal work, paperwork. Go get the mobile vans, get outreach workers out there talking to people who are currently using drugs. You can't get more people into treatment if you don't talk to people who are using drugs, right? If you wait till they stop using drugs, it's kind of defeats the point. And then I have no issue at all with AA and NA. It's helped millions of people. And for a lot of people, that is the perfect program. And they love it, and it touches them, and it changes their lives. And God bless. That is wonderful. There are a lot of people who are addicted to powerful substances like fentanyl or methamphetamine in particular that need to be on medication. And so I would say let's nothing wrong with policy debate, but really, if there's someone who's out there using drugs, our systems, our government systems, our NGO systems needs to be in touch with the current people who use drugs. If we're not looking for them, if we're waiting for them to knock on the door of the treatment center, we're doing something wrong. And this is being done. and people know how to do it. It could be done through police facilitated deflection,
Oh.
where either an officer working with the community or family sort of engage with someone who may need help getting into treatment and facilitate access to that treatment. It could be done through drug treatment courts. But the first thing to say is you got to start by looking for your clients and your customers. If you're a treatment center and you're a brick and mortar center and you're just waiting for people to show up, you're not doing it right, because you're the people who need the services are out there. So yeah, I think that's the number one priority. It's just, at most, there's been different studies, but at most about a quarter of people with an opioid use disorder are getting quality treatment.
Right.
And with the dangerousness of the drugs that they're consuming, that's terrible, and we shouldn't be satisfied with that.
Yeah, I want to re-emphasize that number you said. At most, a quarter of people who need treatment are getting it. And we've seen for years that number hover more like 1 in 10, especially in the South. You mentioned meeting people where they are, quite literally. Nashville's overdose unit, through their police department, has been particularly impactful in this way. They go out to where people who are frankly destitute or unhoused, homeless, meets them where they are, finds what kind of substances they're using, gets them naloxone, gets them set up with partner organizations for treatment options, recovery support. It's been pretty instrumental in saving lives. And similarly, we also see first responder programs like Quick Response in Hamilton County, where Chattanooga is, for example. They've recently launched a program built out of their EMS that has a follow-up. So if there's an overdose response, there's follow-up with that person to get them connected. So yeah, it is exactly that kind of thing you're talking about, that kind of strategy of engaging people actively using and not just waiting for them to say, yeah, I'm ready for something now. Because you're right, if you wait for that, they could quite literally die with the lethality of the supply these days. So in thinking about that, as almost a public health framework, the lethality of the problem, you mentioned in the early 2010s, there wasn't enough urgency yet, and that we missed the mark, and in that way, and fentanyl hit systems that weren't prepared to handle it. Have we changed course? Have we started meeting the moment? Are we adequately addressing this for the public health crisis that it is?
It has moved in the right direction. And I want to say that a lot of people in Congress, the executive branch, and state government have done a lot. There have been more investments and more focus. And so on the one hand, I want to give credit to that hard work that's occurred. But on the other hand, we have never scaled the response to meet the need. And it's hard to draw an analogy, but of the literally $trillion of federal commitments for COVID, which obviously is a problem and it was an emergency. And however, I mean, I wish there was a similar emergency supplemental for anti-drug efforts. In my book, I was trying to be disciplined in thinking about, okay, what do we need to really move the progress forward? And I proposed a 20% increase federal drug budget. And even for us in Washington, big numbers can be like hard to keep track of, right? Because, but we have a federal drug budget of about $46 billion. That's supply and demand. That's everything. So that's a big number, but we're a big country and it's a complicated problem. I proposed $1 billion a year in about a 20% increase in federal spending targeted in these programs that have proven to be successful around the country during this crisis, but are not yet scaled. So I see that's the thing that I think it really drives me a little bit crazy, because we know everywhere around the country there are model programs and policies that people on the ground in their state, in their city, in their town, they have worked on, they have developed, they have perfected or improved, that can be adapted and taken to everywhere in the country, but we're not funding it. We're not funding programmatic federal resources to take say, police facilitated deflection, which again is popular and is in a lot of places, hundreds and hundreds of places, but we need thousands of programs. There's so many police departments and fire departments and others who could do this with some federal resources. And it's the same across the board with other innovative programs. And I think sometimes people like you and me who are focused on drug policy, we visit these and we hear about these great programs and we think, okay, this is a no-brainer. That's the way I felt when I first was in Providence, Rhode Island, and I met recovery coaches who were going to meet people after their non-fatal overdose in the hospital and helping to transition them into treatment and just to work with them. And I'm like, oh my God, recovery coaches, this is such a great idea. So there should be recovery coaches everywhere. I proposed that the federal government fund hiring 100,000 recovery coaches across the country, which is a bit of a callback to President Clinton calling on 100,000 community police officers back when he was president, maybe a bit before your time. But recovery coaches can do something that nobody else can do. They can develop quickly rapport with people that are current drug users.
Yes.
And they can be sort of a trusted interpreter and translator to say, hey, Richard, you've been coming here into our clinic, for some services, but you've been using drugs for a while. We have this buprenorphine clinic, or there's this doc over here, this nurse practitioner. Let me go over and introduce you, and we'll see if you like it, if you're ready for it. Right. And I think it's a shame because there's all these people in recovery, almost 25 million American, many of them want to give back and share what they've learned. We ought to be hiring them and putting them to work and bringing all these people with an addiction problem into some level of care. And frankly, nobody could do it like someone with a lived experience because it's just hard. It's hard for someone in the middle of an active addiction to listen to someone, to even a well-meaning doctor or a nurse who feels they don't understand their life. Someone who's been there can do it. Yeah. So let's get going. It's so much cheaper to get people into treatment and care earlier in their addiction than have them go into the emergency department or struggle or have require a 911 call and EMS response. So really, we're wasting resources and lives, and we can do a lot better. So that's a couple $2 billion a year program, 1.8 billion, and it would be a great investment for the American people. So to answer your question, no, we're not doing enough. We haven't committed to what it takes, and there are more people who are going to be lost that don't need to be.
So that trust is a critical element of this, and that's something that peers bring to people struggling with substance use disorder. Establishing that trust. In terms of informing people across this landscape, this is multiple sectors: healthcare, law enforcement, criminal justice, recovery support, on and on and on. Different people, different sectors. The media landscape and the information landscape is chaotic, to say the least. Even more so now in the age of AI, on top of social media, on top of fragmented media ecosystems, and on top of everything else, right? So how are you finding is the best way to communicate new changes in drug supply, new changes in policy ideas, new threats? What is the best way of communicating with people on this issue? And do you feel you're getting through?
Yeah, Jeremy, it's a really important question about how we're communicating to the public. And there are different ways to answer it, and there are different channels. But I would say, especially for young people, adolescents, we have just decided as a country not to give every student in the United States evidence-based drug prevention and education information. They're great programs, but the country eliminated in the Obama administration the Safe and Drug-Free Schools program, which provided direct grants to school districts around the country. That was an almost $300 million program. It's gone. There's no direct federal resource to educate our students in schools. There is a set aside, a 20% set aside into the two large grant programs. So there is some federal money coming in. So we ought to decide as a goal, every student in America should get evidence-based, age-appropriate information about curricula about prevention. At a younger age, it's more about resilience and social interaction and behavior, understanding your emotions. As you get older, it's more specific, but we know how to do it, but we're not funding it, and that needs to change. And just also, I was just in the UK and I was walking around and I took a picture of it. I saw this ad for a sneaker company that had the slogan "Above the Influence." And I don't know if you're old enough, Jeremy, to remember, but Above the Influence was the national brand for ONDCP's anti-drug media campaign. It was at its peak about $180 million federal dollars matching grant spending, matching spending by the private sector to provide advertising. We need that. And what we've done now is to be honest, if I could just be blunt, we're doing it on the cheap. We get a chunk of money, a couple 100,000. We worked, ONDCP's done some good work with the Truth Commission. They produce some ads, they roll them out, they get some free media, but they're not advertising strong anti-drug messages, evidence-based, focus group messages, the way Coca-Cola is advertising. Right? Yeah. They're not doing it. And we know advertising works because these big corporations wouldn't be spending the billions and billions in advertising if they didn't know it works. So we know how to do it. We've done it in the past. Above the Influence was very successful. It would have to be, I'm not saying we have to use that slogan. You have to do what works for the target audience. But I think a couple $100 million, which is what I proposed in my book, a year to have strong media messaging to young people, again, with the messages, the slogans, the whole design, not based on what people like me in my early 60s think, but what the target audience think is effective. Because we know advertising works. Take a lesson from Coca-Cola and let's invest in good messaging for our young people. It's just a dereliction of responsibility that we're not doing media messaging and doing it on the cheap.
We are seeing in the data, fortunately, though, that Gen Z is using at lower rates. We're still seeing issues amongst millennials and Gen X, and this is largely a millennial problem now, younger Gen X, older millennials in particular, in terms of the fatalities. In terms of that targeted media, I suppose that's what you're talking about, making sure we're continuing to see what's working with Gen Z and then targeting the messages to the people who are currently using at the highest rates? Or do we need to ensure that Generation Alpha, who's currently in the single digits and early 10s, 10, 11, 12, et cetera, what are the different problems you'd expect for these different generations?
Yeah, it's interesting how it works with different cohorts. Well, I think that it is likely that sort of what they said in the crack epidemic, where the younger brothers, younger sisters, they've seen their aunts or uncles, their parents maybe had problems with fentanyl use. And just like crack became sort of less appealing to people, that there's an understanding. I mean, I hope and I think that people have gotten the message, young people, that you just can't take a pill from anyone. It should be like how you tell your kids, more so your daughters, but same with anybody, don't take a drink from somebody you don't know in a bar, right? Right. Go get your own drink or see it, watch it come out from the bar. You can't take a pill from anyone because even your good friend who's trying to help you out because you can't sleep and you need a Xanax may have gotten it online. So I think that it's interesting because adolescent overdoses have risen a lot and they plateaued a bit recently, but the drug use is down. Right. But the consequences are higher because the risks are higher. So that's good. But we got a lot of challenges on the horizon. Certainly, I'm worried about high-potency cannabis use, especially among young people. I see that the tobacco, nicotine in various forms, whether you're taking it as like a chewing tobacco, you put it in your gum, that little packet you can get, and alcohol is still an issue. So I think the same science still applies, is you want to discourage initiation, illegal alcohol, tobacco, or drug use of any kind among young people, delay it, hopefully prevent it, but delay it. And I don't think we've seen evidence of people moving from high potency marijuana into hard drugs where I can draw that conclusion, but I'm worried about it because traditionally, right, a certain percentage of people try one drug. A lot of people just stay there and that's all they go, but a certain percentage after using one drug for a while, look for something else. And, having a generation of young people initiate marijuana use with these extremely powerful, high potency products is concerning. And frankly, it's the National Center on Drug Use and Health reports that about 20 million people with a cannabis use disorder, 3.6 million or so with a severe marijuana use disorder. People still walking around thinking you can't be addicted to marijuana.
Yeah.
It's like, frankly, it's like I respect whatever a state wants to do. If a state wants to have recreational marijuana, if they want to have medical marijuana, if they want to keep it illegal, I think that's where we are in the country. But we've got to get people information. People think, oh, it's natural, it's organic. These products they're buying in these stores are highly processed. I actually went into I was in a state that had legal recreational marijuana, and I went into the store to look around. And, there's a lot of money in marketing and advertising. One of these products was describing, they had actually a pouch that you put with a THC pouch that you could put in your between your teeth and gum. And it said, and the advertisement said, stay high all day and nobody will know. And I'm worried about the creativity of the private sector. We got to do a lot better on regulating marijuana. We could still allow states to do what they want with their law, but there's no federal system to really assess what's happening with marijuana and to regulate the marketing, to think about whether there should be a THC limit. We could do a lot better. And I don't think it's great that 6% or so of 12th graders are smoking marijuana or using marijuana every day because of the vape pens, the edibles. People can be high all day, right? They don't have to go, out up to the schoolyard. They can just take a edible. Nobody will know. So, yeah, I'm not saying that's the only issue, but it's a problem.
Reining in the creativity of the private sector, that was an interesting phrase for this, because it does seem like that's where most of the innovation of newer drug trends are showing up, is being sold as supplements or some sort of natural herb or something like that, even when they're not, even when they are synthetic. So in one way, we have innovative on the supply side that is putting people at risk. And again, a quick point, you were saying that the overall use being down and the risks being higher amongst youth, I think was a really important highlight. In contrast, what are some of the innovative ideas we're seeing now to fight back against these newer changes in the drug supply, the higher potency, higher risk products, even in the context of a shifting youth landscape?
Oh, certainly we need to continue to invest and expand our investment in testing, because new products come out. And it might have been metamidine and xylazine might have been in the drug supply for 10 years, and we may not have known it if we weren't recognizing it. So we just need to be faster. Things move more quickly. And if it's coming from China, which is the source or the primary source for a lot of these chemicals used to make these, not just fentanyl and methamphetamine, but also these new psychoactive substances and other chemicals, we can try and get these chemicals scheduled, banned internationally, and try and get China to stop sending them our way. So we absolutely need to invest in testing and drug checking so that people know what's in the drug supply. We got to keep doing that and be faster in understanding what's happening and getting the information out and keeping everyone informed.
What are the policies we should be keeping in mind? How should we be thinking about this crisis moving forward?
Oh, I do think we need to focus on the role of the federal government. The federal government supports more than 2/3 domestic anti-drug programs, demand reduction programs, treatment, prevention. And, a lot of the great state programs run by governor's offices, most of them are federally funded. So, I mean, there are millions of people getting SUD treatment, SUD coverage from Medicaid and other federal programs, and they need it. And Medicaid has been doing some important work with making sure people have safe and sober housing, transportation to treatment, recovery support, care coordination, the stuff that we know that works. In a way, I was thinking about how like if you're in the Veterans Administration system, if you're a veteran, you serve the country, you get a lot of support and coverage because you earned it, right, through your service. And that's a more robust system than the general public has, and as it should be. But some people in Medicaid has been learning what works and studying what works and been saying, well, look, people aren't coming to their appointment. They can't get the 3 buses and get there on time. And they've helped figure out these problems. So, there's a lot of good work that's been done. We got to make sure we support what works, we fund it, because we either pay now or pay later.
Anything you'd like to add?
No, I would just say that I do understand that this is a hard problem. But there's a lot we have learned about how to help people and how to get people on a better pathway forward. The question is, are we willing? Are we willing to do what it takes to help more people? And that requires focus, attention, staffing, and especially that initiation. I guess where I'd end, Jeremy, is recovery coaches are so important because there could be that first contact point with someone who's an active drug user and getting them to think about taking some first steps into treatment and care. And we've got to do that. It's like, that's the biggest problem. I mean, there are many problems,
right.
But the biggest problem is that bulk of people who are active drug users, buying drugs every day, risking their lives, are not in any level of care or treatment. And so we've got to go to them and reach them, and no one better than someone who's walked that path of addiction and recovery themselves. So let's invest in our people and get them out there. That they're the workforce that we need. Of course, we need psychiatrists and counselors and nurse practitioners. We need a lot. But the on the ground, let's get those recovery coaches out there. Let's save more lives.
Well, thank you, Richard Baum. It's been a true pleasure having you on the Smart Policy Podcast. I really appreciate it.
Pleasure, and keep up the great work, and let me know if I could ever be of assistance to the important work you're doing in Tennessee.
For more episodes on in-depth discussions on Tennessee policies related to substance use disorder by a range of local experts, please subscribe to us wherever you get podcasts and visit our website at smart.tennessee.edu. I'm Jeremy Corvelis. Thank you for listening, and see you next month.